Welcome to This Explainer. Today, we're essentially stepping into the shoes of a medical detective. Every single time a patient walks into a clinic or a hospital, they bring a brand new clinical mystery with them. And as clinical documentation integrity specialists, coders, and educators, we absolutely know that the first and honestly most vital step in solving that mystery is gathering the right clues. But before we break down the structure of exactly how we document these clues, I want to throw a question out to you. Think about all the incredibly advanced diagnostic tech we have today, right? We've got CT scans, MRIs, super complex lab panels. With all of that at our fingertips, how often do you think a patient's history alone, literally just the simple act of talking to and listening to the patient, reveals the final diagnosis?
Well, get this. The answer is a staggering 76%. Historical studies have shown time and again that the history alone gives us the correct diagnosis in roughly 3 out of every 4 clinical encounters. It's an unbelievable statistic, and it really proves the immense power of subjective data.
So here is our game plan for today, which is going to act as a fast-paced syllabus for this clinical tutorial. We'll be looking at transitioning to SOAP notes, the diagnostic power of the history, the specific components of subjective data, quotes versus medical translation, pertinent positives and negatives, and finally, a critical medical legal alert on laterality. All right, let's dive into Section 1, transitioning to SOAP notes, and looking at efficiency and follow-ups. So when a patient is first admitted to the hospital or seen for the very first time, we have to do a comprehensive history and physical, the H&P. And as you know, it's incredibly detailed and really lengthy. But for follow-up visits or chronic disease monitoring, writing out a full H&P every single time, that's just an unnecessary burden. That's exactly where the SOAP note comes in. Standing for subjective, objective, assessment, and plan, it's the structured, highly efficient format that streamlines care without losing the integrity of the clinical picture. Which brings us right to Section 2, the diagnostic power of history, and why it gives us the diagnostic edge. This really perfectly illustrates why that subjective S in the SOAP note is the foundation of everything. Research by Hampton back in 1975, which was later validated by Peterson and colleagues in 1992, tried to quantify the contributions of history taking versus physical exams and lab tests. And Peterson's team found that history taking led to the final diagnosis in 61 out of 80 patients. That's huge! Despite all our modern tech, taking a meticulous history is time incredibly well spent. It is literally the most crucial step in preventing diagnostic errors. Moving on to Section 3, subjective data, let's methodically deconstruct the components of that S. So, subjective data is exactly what it sounds like. It's what the subject, the patient, tells you. To organize this story, clinicians use these core acronyms. First up, the chief complaint, or CC, the main reason they're there. Then the history of present illness, the HBI, giving us the chronological story of the problem. That's followed by pertinent past medical, family, and social history. And finally, a targeted review of systems, or ROS, to catch any other lingering symptoms. As CDI professionals, we really rely on these specific elements to make sure the clinical picture is complete and compliant. But capturing this isn't always as simple as just typing out a story. In modern EMR systems, clinicians often have to squeeze a patient's very unique, specific complaints into a predefined drop-down menu. So while the subjective info is organic, the EMR demands structure. And that can sometimes create this weird tension between what the patient actually said and the medical terminology we use to document it. And that tension leads us perfectly into Section 4, quotes versus medical translation, focusing on precision in words. The key here is knowing exactly when to use the patient's own words and when you need to translate them. If a patient says they're taking a little red pill for their blood pressure, you wouldn't just guess the medication name, right? The best practice is to actually use quotation marks to protect that exact, vague description. You document that they take a little red pill. But on the flip side, look at how we handle blood pressure. It is entirely clinically necessary to translate that lay term into the standardized diagnosis of hypertension. This balancing act between verbatim quotes and clinical translation is what ensures accuracy and secures the integrity of the whole note. All right, on to Section 5, positives and negatives, exploring pertinent findings. As a clinician is listening to a patient, they're mentally building a differential diagnosis using pattern recognition. And to do that well, they have to document not just what the patient is feeling, but what they are absolutely not feeling. So a pertinent positive is a symptom that's present, which supports a suspected diagnosis. A pertinent negative is a documented absence of a symptom, which helps rule a diagnosis out or at least makes it way less likely. Let's look at a classic example to see how this works in practice. Imagine a 22-year-old guy comes in with right lower quadrant abdominal pain. The clinician immediately thinks, okay, acute appendicitis. Now, patients with appendicitis almost always present with anorexia, meaning a complete loss of appetite. If he says he has no appetite, that documented anorexia is a massive pertinent positive pointing right at appendicitis. But if he asks when he can go grab a burger because he's starving, that documented hunger is a pertinent negative. It doesn't 100% rule out appendicitis, but it strongly points away from it. Documenting both sides is what actually justifies the medical decision-making to auditors. Finally, we arrive at Section 6. This is an area where simple errors have severe consequences. A medical legal alert on laterality. So there is a legal vulnerability here that is honestly a bit terrifying. When you're dealing with a condition involving a body part with laterality, a knee, an eye, a kidney, you have to specify left or right consistently throughout the entire note. As the source text warns us, even a single discrepancy between the subjective history and the objective physical exam regarding left versus right can instantly destroy a provider's credibility. If litigation happens, malpractice lawyers will eagerly search for these exact discrepancies to raise doubts. Consistent laterality isn't just an ICD-10 billing requirement, it is a critical legal shield. Ultimately, the subjective portion of a SOAP note is so much more than just transcribing a conversation. It's a highly structured, validated narrative that builds the foundation for accurate diagnoses, compliant billing, and a rock-solid medical legal defense. Every single quote, every translated term, and every pertinent negative plays a pivotal role in the anatomy of a perfect note. It really makes you wonder, if one wrong word can unravel a diagnosis, what other hidden traps might exist in your charting? Thank you so much for joining me for this explainer, and please like, share, subscribe to Decode Healthcare with Harshal.